Good morning for those who are joining. We're going to wait another 2 to 3 minutes and then we'll go ahead and get started. Thanks for joining today and we look forward to chatting soon. All right, everyone, let's go ahead and get started. I know that it is a lovely Wednesday morning and plenty of things are on the docket today, but we're very, very excited to get started and have our guests with us. So first and foremost, let me go ahead and start with some quick introductions. So my name is Lauren Crawford Shaver. I'm the Executive Director of the Partnership for America's Healthcare Future. We're an organization leading doctors, nurses, clinicians, hospitals, insurance providers, biopharmaceutical companies who are all committed to make sure every American has access to affordable, high quality coverage that they deserve and need. We were founded just over 4 years ago with an important mission to build on and improve what's working, where private coverage, Medicare, Medicaid all work together to expand access on coverage, on care, on fix what's not working. Whether it's called Medicare for All, the buy-in, public option, Medicare at 60, as we'll be discussing today, we don't think those are viable paths to achieve those goals. And we're looking for alternatives, and we're looking at the success of our system, where we have failures in our system and what we can do to support and build upon those. I would say over the last couple of years, one interesting thing we have seen is that we have had great coverage gains during the pandemic to make sure people have the healthcare that they need and the coverage that they need. And we look forward to continue to build upon that success in the future. But we are here today to discuss a report we're rolling out. We're very excited about this report. It really helps us continue to drive important narratives, important information that really talks about the distributional costs of Medicare at 60. We have heard proposals come out of thinking about Medicare at 60. What is it? What does it look like? And what does it actually mean for people who currently have Medicare, for those who don't, to our broader healthcare system? And we worked with two very close friends of ours, Tom Church and Dan Heil, to take a look at this, to say, what kind of analysis can we put together and look at what the impacts would be. So we are very fortunate that Tom is with us today to talk about the report, to talk about some of the top line findings, take some QA, and answer any and all questions that you all might have. So with that, I'm going to turn it over to Tom to go ahead and talk about the report we released just this morning.
Thank you, Lauren. As Lauren said, my name is Tom Church. I'm a policy fellow at the Hoover Institution. This is actually the second analysis that I've worked on with my co-authors on Medicare at 60. Now, the first one we called the fiscal effects of Medicare at 60. And we wanted to study, well, since CBO hadn't scored it yet and still hasn't scored it, although it looks like they'll have a score pretty soon, we wanted to score how many people would go on Medicare at 60, were to be put in place, and how much would it cost. At one point, President Biden suggested that, this expansion would be paid for with alternative financing, with some sort of alternative financing outside of the Medicare trust fund. And so for that reason, we looked at, what reimbursement rates would look like if they stayed at a constant rate in order to, drive down the federal costs. However, we did find that it costs something. This is the unavoidable part of Medicare at 60, is that expanding insurance access to millions of Americans, subsidized access, costs money, and eventually someone has to pay for it. So that first analysis came up with a federal deficit effect of about $400 billion over its first 10 years. An additional 14 million Americans would be enrolled in Medicare, that is adults aged 60 to 64 not currently enrolled on Medicare. About 8 million of those would go into Part B, 14 million in Part A, about a million less than Part B would be in Part D. The costs would be quite large. I mean, that's the federal deficit effects. Medicare gross spending, we project, would rise by over $1 trillion over 10 years for this expansion of just this 5-year age gap. Like I said, since it was being talked about as something that would be paid for, we looked at it in terms of constant reimbursement rates. As you know, private insurers are reimbursed at higher rates from physicians and hospitals than care provided under Medicare and Medicaid. That drives a lot of the costs going forward. Now, fast forward to this year, that original paper looked at the cost, how many people would go on it. We wanted to know, of the group who would sign up for Medicare at 60, would there be winners and losers? How much better off would they be? Would other people be made worse off? And so that's why we call this one the distributional consequences of Medicare. Now, critically, we also looked at reimbursement rates, and since we're in a time of trillion-dollar deficits and rapid inflation and trying to hold down budgetary costs, we made the decision to look at what would happen if reimbursement rates followed current law projections. That's important because right now, current law says that reimbursement rates provided by Medicare and Medicaid to physicians and hospitals and other healthcare providers will fall over time. That allows the government to save money, but it also means that revenue for these healthcare providers falls drastically over time. And that's kind of the ball game. Now, you might want to know, how do you even make these sorts of estimates? This paper and the last paper are built on a model that my co-authors and I have worked on for a bit to replicate CBO's HISIM2 model. This is their health insurance simulation model that allows them to project forward healthcare expenditures, health insurance coverage, premiums, all sorts of information. Now, to do that, we start with, we use public use data sets. We use the annual supplement from the CPS. This gives us great demographic data on everyone in the country. It gives us income data, labor force participation, a whole host of other information. To get good healthcare data, though, health consumption, health spending data, we use MEPS HC, the medical expenditure on panel survey household component. We put those two things together and you end up with a great picture of the United States, how much everyone spends, what everyone's situation is. And then on top of that, for projections into the future, we use official estimates from NHE and from CBO. Like I mentioned, the second paper is different because these reimbursement rates fall over time. Especially under MACRA 2015, reimbursement rates are projected to decline significantly, especially for physicians over time. What we end up with is a model that is a microsimulation of the United States. It gives us healthcare spending, it gives us insurance premiums and statuses. And this paper, we beefed it up so that we could break down spending and changes by healthcare category. So think physician payments, inpatient, outpatient, emergency services, and the like. Type of payer, that is this coming from the federal government, private insurers, individuals, and then by Medicare part. So let's get to the findings of this actual study, the distributional consequences. Here's the 10-year snapshot. In the first year, at least, we estimate that it would increase. And by the first year, I mean, if we put this in place next year, open enrollment this fall, the federal deficit would increase by a little over $42 billion. Now, over 10 years, we estimate that it would increase the deficit by $450 billion. And that is excluding federal interest costs, which right now seem to maybe be going up because inflation is on the rise and payments on debt are going up as well. Now, this expansion of 60 to 64-year-olds would make a newly eligible population of a little over 17 million people. We estimate that, like the first paper, about 14 million people would enroll in Medicare Part A, a little over 8 million would enroll in Part B, and then a little under 7 million would enroll in Part D. And when we dive into who'd be made worse off and who'd be made better off, our findings suggest that Medicare at 60 is surprisingly poorly targeted to helping those most in need of affording medical care, the medical needy, or just those who have trouble paying for insurance who aren't there already. So what do I mean by that? The likely winners of this new policy, this newly eligible group going on Medicare at 60, would include many high-income individuals. So relative to the adults who would not be eligible for Medicare at 60, the newly eligible group tend to be higher income and also more likely to already have insurance than the group that remains ineligible, the adults that remain ineligible for Medicare. Something like 9% of the eligible population is uninsured and over 13% of the ineligible population is uninsured. The high income earners, those who are newly eligible are much more likely to have incomes over 400% of poverty than those who remain ineligible for Medicare at 60. I think even more of a troubling result is that we estimate that over 1/3 of individuals and families on the ACA getting their insurance through in the individual marketplace would see their combined premium shares and out-of-pocket payments rise under this proposal, which is pretty shocking. It's just because we go from, the ACA has different requirements than when it comes to cost sharing and premium payments and subsidies than does Medicare. The group that would be most likely to be harmed on the ACA from expanding Medicare at 60 are those between incomes of 135 to 250% of poverty. Now, this happens because the ACA sets up a premium amount based on the benchmark plan, silver benchmark plan, and then caps what the allowable premium is for an enrollee. So a little bit above 2% of income, everything above that gets subsidized. Now, Medicare, when you sign up, when you're enrolled, requires you to pay premiums for Part B and Part D. And there are cases where those premiums can be more than 2% of your income. And so that's where this little gap goes in. Now, we did assume that anyone who's newly eligible who would be forced to go on Medicare would be forced to go on Medicare. So this means if you're on the ACA, you're not going to be allowed to stay on the ACA, you shift over to Medicare. If you are on retiree healthcare, you also get shifted over to Medicare. And this is in line with existing Medicare late enrollment penalties. So if you qualify for Medicare right now and you don't sign up and you don't have a qualifying medical plan, in other words, you're not working and receiving health insurance, and you don't sign up, you have to pay a late enrollment penalty for parts B and D. And that's so that you don't delay and mess with the risk pool in Medicare. So we assume the same stuff. Now, who else is affected? Marital status ends up being quite important. You can this switch leads to funky interactions between the ACA and Medicare. A couple who is on the ACA and one individual in that couple would qualify for Medicare at 60 and the other doesn't, means that the ACA subsidy, the ACA required payment, would remain. And this new person going on Medicare would then also need to pay the Medicare premiums. And that way could end up paying more under this plan than not expanding Medicare at 60. All right, so let's talk reimbursement rate changes, because this is where things get, I think, really fun. But then again, I'm the nerd who likes to work on big data sets. If Medicare at 60 were enacted and reimbursement rates followed current law, that's under MACRA, that's under this projected decline from CMS for physicians and for hospitals, aggregate payments in the first year would fall by about $15 billion combined for hospitals and physicians. And in this first year, it mostly comes out of inpatient hospital reimbursement. So hospitals would face the brunt of it. About 12 billion of that would come from hospitals, and about $3 billion would come from physicians. Now, over time, these numbers just get larger, but due to MACRA especially, holding physician repayment rate increases down, physicians start to pay more and more of that aggregate fall. We estimated that out to 2042, that in real dollars, that is inflation adjusted, inpatient hospital services would fall by $21 billion in that year, and physician payments would fall by $35 billion in that year. So compare that to this first year of 12 billion and 3, and now we're at 22 and 35. So it's a big deal. I'll also mention that this matters, especially in hospitals, which might not have the greatest profit margins. Our estimate suggests that maybe profitability would fall by 25% for the median hospital, And so if you're a hospital with below average margins, that's even more. That's the difference between maintaining and perhaps closing. It's not great. Medicare at 60, I think one of the keys here is no matter what, it's going to cost some money. And it comes with this unavoidable trade-off that someone's got to pay for it. It could be new enrollees, and they pay a small share, but again, it's Medicare, so it's subsidized a bit from taxpayers. It could be physicians and hospitals through lower reimbursement rates, and it could be taxpayers. The idea is just you have to decide who you want to shift those costs on. Now, there are other trade-offs that we can talk about in the Q&A. There could be clawbacks, which we didn't assume here from states. And we haven't talked about prescription drugs here, which is a whole other conversation. I will say, when you look at the quick snapshot of winners and losers, there are some who definitely benefit and some who don't. One of the winners I haven't talked about much here are actually state governments, because state governments are paying a share of their Medicaid recipients. And those Medicaid recipients who are 60 to 64 would be shifted onto Medicare. And so states would actually make some money back because they wouldn't have to pay for those Medicaid recipients unless the government put clawback provisions in like they did back when we passed Part D. Companies with retiree health obligations paying for their retired workers who they're covering their health insurance until they go on Medicare would also be better off because they'd be allowed to shift their retirees onto Medicare and become secondary payers, not primary payers. Now that kind of gives you an idea of who the losers would be in this plan. If you're on retiree health care, you're going to end up having to pay premiums for Medicare. If again, if you have enough income, you're going to be paying income-based payments on Medicare as well. And then, like we said, a good amount of ACA recipients look like they'd have higher out-of-pocket required payments, premiums or others for their healthcare. And then, of course, I think doctors and hospitals, no matter what, are going to see losses in revenue from these reimbursement rate cuts. And we'll go from there. So, Lauren, I'll turn it back to you. There's a lot in this paper. Please take a look, but those are the highlights, and I can answer any questions anyone might have.
Excellent, Tom. Thank you so much. As with all of our papers from the partnership, if you go to americashealthcarefuture.org and click on the resources button, you can download all these reports, any one page or any of these top line findings that Tom was able to walk through and make sure that you have the resources available to you. But with that, I'm actually going to jump into a question kind of at the end here about winners and losers you asked. I have a couple of questions for you. And if folks have any questions, please use the chat box and we'll be able to answer those with you today. So you were just talking about winners and losers. You talked about, folks who currently have healthcare outside of Medicare and on their retiree plans. They might have Medicaid. They might get something on the exchanges with a subsidy. What is expanding Medicare to those at 60 do to those on Medicare now and the overall kind of structure of that system?
It's an interesting question. Well, there's a few things a few ways we can look at this. One is that you're adding 14 million more people to the Medicare system. That is to the system of doctors, the networks of hospitals, everyone who takes Medicare patients. So what this could mean is for existing Medicare patients, maybe longer wait times to see doctors, and especially in the short run. We're adding 14 million people to the 60 or so million people already on Medicare, and the number of new doctors, nurses, facilities doesn't increase by that same percentage in that first year at least, and will take many, many more years to catch up. So you're looking at probably less access in the short term in terms of wait times, or even physicians or outpatient facilities, any of them who accept Medicare patients simply because they're not able to get to patients. It's an open question as to what it will do to premiums for Medicare recipients. This is one of those things where we need really, really good data in order to find what happens to required premium payments over time. And your mileage may vary. We're not exactly sure. I'm looking forward to seeing if CBO ends up coming up with that estimate, but it could go either way there.
Yeah, we're putting a lot of people on a system that's already a little strained. So we really have to do things like this, really look at the consequences. What are the impacts that people have in their real life, in the financing of it, and how is it paid for? and then the finances for all the healthcare delivery pieces, which leads me to my next question for you. On the hospital front, in your report, and as in your previous report, we talk a lot about hospital finances. And obviously, as a consumer or as an outside individual, what does that actually mean in terms of a consequence for a hospital? If you're going to say the hospital is going to get 20%, 30% less revenue, what does that mean to me as a consumer? And what does that impact on the change that I may have or may see?
Well, it's not necessarily great, right? First, let's take the case of rural or community hospitals, which already receive a little bit, higher payments from the federal government in order to stay open. I don't know. I mean, how much the audience has spoken to hospital administrators. I haven't met one who said, we're in a great financial shape. I think they're always worried about their patient mix, how to pay for everything that's there, and turning to them and saying, all right, you're now going to receive many percent less in revenue than you get right now. Good luck. Well, that has downstream effects, I think, everywhere. You're able to hire fewer nurses. You're able to work with fewer physicians. It just means, I think, less. The quality of care ends up going down simply because you're not going to be able to staff up as much. I think what you hope for when you walk into a hospital is that there are plenty of people, there are plenty of beds, there are plenty of physicians available. You can get rapid care, rapid and quality care. And I think that starts to degrade over time when you don't have enough money. I mean, having enough money is terrific. And in healthcare, it's always a squeeze.
Absolutely. And I'll just help piggyback on that. I think hospitals, as we've seen in their finances, continue to have a mix of private insurers, Medicaid, Medicare. They have charity care programs. They have a variety of programs to make sure that if you walk into a hospital, you get the coverage you absolutely need. And that mix finances the hospital, its growth and its needs and role within the community. So obviously, taking a huge section that they had originally take and plan in as revenue across their employee, their investments, all those pieces would have a huge hit. And I think as a consumer, especially in some of the smaller hospitals or more rural areas that don't have a less dense population, would definitely feel a hit to their hospital and their ability to have the new and most advanced treatments that we see and have today. One thing I noticed in the highlights in your report that came out is that you called out 3 states, Wisconsin, Washington, and Colorado, where Medicare 60 would have large effects per enrollee. Can you just quickly talk through about what those large effects are in those 3 states?
Sure. So, we've talked a lot about reimbursement rates for physicians and hospitals and other providers, but they're not uniform across the United States. So CBO has put out a very handy, helpful report looking at the differences in reimbursement rates relative to private payers across the United States. Now, some of the sample sizes are small, and so it gets a bit noisy, but luckily, CPS is a very, very large data set that we built this off of. And so there are some states that reimburse for Medicare at relatively high rates compared to private insurance. There are some that really, really don't. And so these states that you mentioned reimburse at low rates relative to private insurance. And so that means relative to other states, the cuts to physicians, the cuts to hospitals will be much more painful, I guess, in those states. Yeah.
Excellent. And they're populated states. So to your point on data sets, there are people there.
Indeed.
So I have one more question for you. And I just want to talk a little bit about the cost here. We've thrown some really big numbers in terms of cost in there. So if you I'm gonna throw them back at you and help a general healthcare consumer understand and process what this could mean for them. And I think that's kind of, again, what we've talked about in this report here is someone's got to pay for it. So what could this mean for an individual? You're going to say gross Medicare spending would rise by $1.2 trillion over a 10-year window. You say that lowering the Medicare eligibility age to 60 would add $42.6 billion to the federal deficit in 2023 and increase your deficits by $452 billion. What does that mean for, the mom in Wisconsin who's thinking about their parents' care and their kids' care? What do those big numbers mean?
What it means is that we're not going to be able to afford to help as many people, I think, as we want to help afford healthcare or health insurance. The federal budget is tight right now, right? We're coming down from enormous spending to combat COVID-19. And yet we're still looking at permanent deficits of over $1 trillion. What that always means is that we're squeezing out the priorities and the ability to help those who need help. I think it means that if they're relying on federal subsidies or federal or state subsidies in some way to purchase their healthcare, and to some extent we frankly all are, that ability just isn't going to be there as much. So getting care that you need for your elderly parents, for your family members, it's going to cost you more. It's either going to cost you more, or you're frankly not going to be able to get the care that is required for you. And that's why, you'd hope that any plan that we put together to help people will be financially sustainable, will give us more flexibility to target this in a better way. I mean, I mentioned this paper is called The Distributional Consequences. It was striking to me that, again, program designs are weird. Things shake out at different income levels. That the winners from this look like mostly will be people above 400% of the poverty line. It should probably be the other way around. I think, what does it mean for them? It means they might look at this and say, why are you helping them and not me?
Thank you for that. And I appreciate folks who've joined and asked questions throughout. Thank you very much. I think what I'd like to do in wrapping this up is talking through one of the things that we really ask at the partnership when we look at these proposals. When we look at a public option proposal, a Medicare at 60 proposal, a Medicare for all proposal, we ask ourselves the question, what is it that we are trying to solve for? And is it an access question? Are we trying to get more people coverage? Are we trying to rein in costs? Are we trying to focus in on a very specific niche issue or a population that currently doesn't have access to coverage and solving that? And this proposal, as we've borne out in the multiple analysis you've now done for us, simply shifting Medicare to 60 has unintended consequences to kind of the points you've raised. It's going to cost taxpayers more money. There will be fundamental changes to Medicare to people who already have it and are currently on it. There, as you alluded to in this analysis, I think it's important, is if we're trying to get access, trying to solve an access question, you're actually not fixing an access question, because the people that would benefit the most from this, to your point, are typically 400% above poverty level. So we really have to ask ourselves, what are the intended consequences of these proposals? And then what are the unintended consequences, so we can really get our heads around them, rather than just talking about the broader concepts of healthcare for everyone or Medicare for all. Because we at the partnership completely agree with the concept that every single American should have access to affordable, high quality healthcare, no matter where they live or how much they make. We just see a different path in getting there than some of these proposals. So with that, I really thank you for your time, Tom. Thank you for your time for doing this research for us. It's incredibly informative. I thank folks who joined here, and I encourage everyone to check out americashealthcarefuture.org. Again, all of our reports and research is up on that website, downloadable. Good word for today, downloadable for everyone to use and leverage. And we look forward to continuing this conversation. Thank you all for joining.